Welcome to the deep dive. You're here because you want to get a really solid handle on bronchopneumonia, right?
Mm.
Think of it, well, simply as inflammation hitting those small airways deep in your lung.
Yeah, the lower airways.
Exactly. We've pulled together the key info from our revision notes for this, aiming to make it really stick for when you need it most.
Absolutely.
So think of this as your focus session to really nail the essentials.
Sounds good. So let's start with the basics. What is bronchopneumonia?
Okay.
Well, at its heart, it's inflammation and usually infection affecting the bronchioles, those smaller tubes, and the alveoli themselves.
The air sacs.
Right, where the crucial oxygen exchange happens.
Mm.
Now, the thing to really grasp is its patchy nature.
Patchy. How so?
Unlike, say, lobar pneumonia, which might take out a whole section, a whole lobe, bronchopneumonia tends to show up as these scattered spots of inflammation.
Ah, okay.
These areas of consolidation, they're spread across multiple lobules. And typically you find it more towards the base of the lungs.
The bottom parts.
Yeah. You might also hear it called lobular pneumonia for that reason.
Lobular pneumonia. Okay.
And just a point to keep in mind, it often affects the very young, so infants and children, and also older adults more commonly.
Okay, so patchy inflammation, often lower down, common in kids and the elderly. Got it. Now, what actually causes this? What kicks it off?
Right, the etiology.
Mm-hmm.
Our notes break this down quite nicely, actually. We can think about bacteria, viruses, fungi, and then a few other sort of miscellaneous causes.
Okay, let's start with bacteria. Who are the main players?
Well, you've got the usual suspects, really. Streptococcus pneumonia, that's a really common one.
Streptococcus,
And Haemophilus influenza. Then there's Staphylococcus aureus.
including MRSA.
Including MRSA, absolutely. The resistant strains are definitely a concern. Then you've got others like Klebsiella pneumonia, Pseudomonas or gugrosa,
Pseudomonas, okay.
and even Escaria colon, E. coli. So it's, quite a range of bacteria.
That is quite a list. Is there any quick way to maybe remember some of those key ones? A mnemonic, perhaps?
I could try one. How about some have survived killer Pseudo-Escaria?
Okay, let's break that down.
So some for Streptococcus, have for Haemophilus, survive for Staphylococcus, killer for Klebsiella, Pseudo for Pseudomonas, and Escaria for Escherichia.
Some have survived killer pseudo-Escaria. Quirky, but yeah, sometimes those are the ones that stick.
Exactly. So that covers the main bacteria. What about viruses?
Yeah, what's on the viral side?
Respiratory syncytial virus, RSV. It's a really big one, especially in young children.
Ah, the bronchiolitis one.
That's the one. It could definitely lead into bronchopneumonia. And then, of course, influenza virus. The flu can certainly pave the way for this kind of lung inflammation.
Okay, so bacteria and viruses are major causes, but you mentioned fungi too.
Yes. Less common overall, but important, particularly in certain groups. The main one to know is Histoplasma capsulatum.
Histoplasma.
Yeah. And the key thing here is that while lots of people might encounter it and be fine, it can cause significant problems for people with weakened immune systems.
So immunocompromised patients.
Exactly. If you see respiratory symptoms in someone immunocompromised, you should have histoplasma on your radar.
Good point. And the other causes category, what falls in there?
Well, a common scenario is a secondary bacterial infection setting in after someone's had a viral respiratory illness.
Ah, so the virus weakens the defenses?
Precisely. It creates an opportunity for bacteria to move in. And the other major one here is aspiration.
Breathing something in?
Yeah, accidentally inhaling fluids or food particles, vomit, even small foreign objects down into the lungs. That can definitely trigger inflammation and infection.
Okay, that makes sense. So we know what it is and the various things that can cause it. Who is actually most likely to get bronchopneumonia? Let's talk risk factors.
Right. Age is definitely a big one, as we mentioned.
The very young and the elderly.
Yes. Their immune systems might just not be as strong. And that leads to the next point. Anyone with a weakened immune system, for whatever reason, is at higher risk.
Like from illness or medications.
Exactly. Or conditions like HIV. Also, having underlying respiratory problems is a major risk factor. Think COPD, bronchiectasis, any kind of chronic lung disease really makes the lungs more vulnerable.
Because the airways are already damaged or inflamed?
That's right. And unsurprisingly, smoking is a big risk factor too. It damages the lungs' natural cleaning mechanisms and irritates the airways.
Okay. What else is on that list?
Well, aspiration, which we just mentioned as a cause, is also a key risk factor. So conditions that increase the chance of aspiration are important.
Like decreased consciousness.
Yeah, or difficulty swallowing, maybe after a stroke, for example. Also, being in certain environments increases risk hospitals, long-term care facilities.
Ah, the hospital-acquired pneumonia link?
Exactly, where you might encounter more resistant bacteria as well. Other conditions, like esophageal diseases that might cause reflux and aspiration, can contribute. And perhaps slightly less obviously, previous exposure to antibiotics can sometimes alter your natural bacteria and make you susceptible to other potentially tougher infections.
Right,
Yeah.
disrupting the normal balance. Okay, so we have the what and the who. How about the how? How does this process actually unfold inside the lungs, the pathophysiology?
Okay, so it typically kicks off when those microorganisms, the bacteria, viruses, whatever, get inhaled or aspirated down into the lower airways.
Down past the main bronchi?
Yes, into the bronchioles and the surrounding lung tissue, the alveoli.
Yeah.
Once they're there, they start to multiply. The body recognizes these invaders and mounts an inflammatory response.
The immune system kicks in.
Right. It sends inflammatory cells, releases chemicals, but this whole process leads to fluid and cellular debris building up in those small airways and air sacs.
So it's like a traffic jam of inflammatory stuff.
Kind of, yeah.
Yeah.
And this buildup causes the lung tissue to become dense and solid in those patches. That's the consolidation we talk about.
Instead of being airy, it gets clogged up.
Exactly. And when those areas are consolidated, they can't do their job properly, which is gas exchange.
So less oxygen gets in.
Precisely. Impaired gas exchange leads to reduced oxygen levels in the blood, and that's what ultimately causes many of the respiratory symptoms we see.
Okay, that step-by-step makes sense. Now, if someone comes in with symptoms like a cough, fever, feeling breathless, what else might be going on? What are the main differential diagnoses?
Yeah, really important question. You've got to consider other types of pneumonia first, like lobar pneumonia, which we said affects a larger area.
The non-patchy kind.
Right. Then there's bronchiolitis, especially in infants, which is inflammation primarily of the smallest airways, the bronchioles. Pulmonary edema, fluid in the lungs, usually from heart problems, can look similar sometimes.
Shortness of breath, maybe crackles.
A lung abscess, which is like a pocket of pus in the lung, is another possibility. And of course, other more general respiratory infections need to be considered too.
So a few key things to rule out. What about how common this is, and where do we tend to see it most? The epidemiology.
It's actually quite hard to get exact prevalence figures for bronchopneumonia specifically.
Why is that?
Well, partly because it might be underreported, or sometimes the specific type of pneumonia isn't always differentiated in reporting. Diagnostic criteria can vary a bit too.
Okay.
But what we do know is that it's seen more often in hospital or healthcare settings.
The hospital-acquired link again?
Yeah, a lot of hospital-acquired pneumonia presents with this patchy bronchopneumonia pattern. And reinforcing what we said earlier, it's definitely more common in older adults and people with those underlying health conditions. They're just more susceptible.
Right. So let's get into what you actually see at the bedside or in the clinic. What are the typical clinical features, the signs and symptoms?
Okay, common things you'll hear about or see are a cough. This might be dry, or it might produce sputum, which could be yellowy-green.
Fun.
Exactly. Fever is very common. Chest pain, sometimes described as sharp or pleuritic, meaning it gets worse when you breathe in deeply or cough.
Ouch.
Yeah. Shortness of breath or dyspnea. Fatigue, just feeling really wiped out. And those general signs of infection, feeling unwell, maybe chills, muscle aches.
Pretty standard infection signs then. What about more severe cases?
In severe bronchopneumonia, you might see obvious respiratory distress. The person is breathing very fast, using extra muscles in their neck or chest to breathe.
Working hard.
Really working hard. You might see cyanosis, that bluish tinge around the lips or on the skin, which means oxygen levels are dangerously low. Confusion can be a sign, especially in older people. And in the worst cases, signs of sepsis, which is that overwhelming systemic response to infection.
That sounds serious. Any differences in how babies might present?
Yeah, infants and very young children can be a bit different. They might just be really irritable, not feeding well, and showing those signs of breathing difficulty like flaring their nostrils. Or you might see their chest sucking in with each breath.
Okay. So how do you put it all together for a diagnosis? What are the key clinical clues?
You'd be suspicious if you see that combination. Fever, a productive cough, maybe their white blood cell count is high or sometimes even low. They're short of breath. Their oxygen saturation is down.
On the pulse oximeter.
Yeah, exactly. And crucially, if imaging, like a chest x-ray, shows new infiltrates or shadows in the lungs.
What about listening to the chest?
Auscultation, yeah. You might hear crackles, sometimes called rails, over the affected areas.
Mhm.
Or you might just notice that the breath sounds are quieter there, reduced air entry.
Okay. And the pulse oximeter can give you that quick oxygen level check.
A very useful tool at the bedside. It might show that low oxygen saturation, hypoxemia.
So clinical picture points towards it. Then you need investigations to confirm, right? What tests do we use?
Absolutely. Imaging is usually key. The first port of call is typically a chest x-ray, the CXR.
And what are you looking for?
You're looking for those multiple, small, patchy opacities, hazy or white areas. They're often bilateral, meaning in both lungs, and frequently more prominent in the lower lobes, as we said.
The scattered clouds look.
That's a good way to think of it. Now, if the x-ray isn't conclusive, or if the patient is very ill, or maybe not responding to treatment, a CT scan of the chest might be done.
Computed tomography.
Yes, that gives much more detail. On CT, you can often see those multiple opacities more clearly, sometimes with a lobular pattern. There's a characteristic appearance sometimes called tree in bud.
Tree in bud? What's that?
It literally looks like small branching lines ending in little nodules, like buds on a tree branch. It represents inflammation and plugging within the small bronchioles. Seeing that can be quite suggestive of bronchopneumonia or certain related conditions.
Tree in bud. Okay, that's a visual to remember.
Okay.
What about finding out which bug is causing the trouble?
Yeah, microbiological analysis is vital for guiding treatment, especially antibiotics. If the patient can produce sputum, sending a sample for culture and sensitivity testing is really important.
To see what grows and what kills it.
Exactly. In more severe cases, or if someone can't cough up sputum, we might need to do a bronchoalveolar lavage, or BAL.
How's that done?
A thin scope, a bronchoscope, is passed down the airways, and a small amount of sterile saline is washed into a segment of the lung and then suctioned back out. That fluid collects cells and potentially microorganisms for culture.
More invasive, but gets a direct sample.
Right. And for specific things, like that Histoplasma fungus we mentioned, blood tests looking for antibodies serology can sometimes help with the diagnosis.
Okay. Any other blood tests that are helpful?
Yes, definitely. A full blood count, or FBC, is standard. In bacterial infections, you often see a high white blood cell count leukocytosis, specifically with more neutrophils, which are key infection-fighting cells.
Neutrophilia.
That's the term. We also look at inflammatory markers. C-reactive protein, CRP, is usually elevated, and procalcitonin, or PCT, is another marker that tends to go up quite significantly in bacterial infections.
And can PCT help track progress?
It can, yeah.
Yeah.
Sometimes PCT levels are monitored to see how well the patient is responding to antibiotics. A falling PCT can suggest the treatment is working.
Okay, so we've used the clinical picture, the imaging, the micro, the bloods. We've diagnosed bronchopneumonia. How do we manage it? What's the treatment plan?
Right, management. The cornerstone is antimicrobial therapy targeting the likely or known cause.
So antibiotics usually...
Most commonly, yes, as bacteria are frequent culprits. Now, the specific choice depends a lot on the setting. If someone's well enough to be treated as an outpatient,
At home.
then the antibiotic choice usually follows local guidelines, aiming for common community bugs. Things like amoxicillin or maybe a macrolide like clarithromycin are often used.
Okay. What about if they're in the hospital? Hospital-acquired bronchopneumonia.
That's often more complex because you have to consider the risk of multi-drug-resistant organisms, MDR pathogens.
The tougher bugs.
Exactly. So you assess the patient's risk factors for MDR. If the risk is low, you might start with a single antibiotic that covers likely culprits like Pseudomonas and MSRA, the non-resistant Staph aureus.
But if the MDR risk is high...
Then you'll likely need broader cover, often starting with 2 antibiotics. You'd want agents active against Pseudomonas, potentially other resistant gram-negatives, and also cover for MRSA, perhaps with vancomycin or linezolid.
So it's tailored quite carefully.
Very much so. We often start with empiric therapy, our best guess based on the situation and local resistance patterns while waiting for culture results.
Broad spectrum first.
Usually. Then, once the microbiology results come back, identifying the specific organism and its sensitivities, we aim to switch to specific therapy, a narrower spectrum antibiotic that targets that bug directly.
De-escalation.
Precisely. De-escalation is key to reducing resistance. Duration of treatment is typically around 7 days, but as we mentioned, PCT monitoring might sometimes help guide stopping earlier if the response is good.
And what if it's fungal, like histoplasmosis?
Then you need antifungals, of course. Something like ketoconazole or itraconazole for milder cases. But for severe histoplasmosis, amphotericin B is often required, which is a potent IV antifungal.
Okay, antimicrobials are central. What else is important in managing these patients? Supportive care.
Absolutely crucial. Supportive care is just as important. This means rest, first and foremost. Symptomatic relief for fever and pain using paracetamol or ibuprofen.
Making them comfortable.
Yes. Hydration is key. Making sure they're getting enough fluids, sometimes intravenously if they're hospitalized and can't drink enough. And, very importantly, oxygen therapy if their oxygen saturation levels are low.
To keep the sats up.
Exactly. Aiming for a target saturation, usually above 94%. We often use scoring systems like CURB65 to help decide who needs to be admitted to hospital based on their severity, confusion, urea, respiratory rate, blood pressure, and age 65 or over.
Ah, see your RB65 for admission decision.
And we shouldn't forget prevention. Counseling patients about stopping smoking is vital, and offering vaccinations, the annual flu jab and the pneumococcal vaccine, can significantly reduce the risk of getting pneumonia in the first place, especially for those in high-risk groups.
Good point. Prevention is always better. So, with all this treatment, what's the likely outcome? How's the prognosis generally?
Generally, with prompt and appropriate treatment, the prognosis for bronchopneumonia is favorable. Most people do make a full recovery.
That's good news.
It is. However, the outcome really depends on a few factors. The person's overall health and age play a big role. Healthier, younger individuals tend to do better. The specific bug causing the infection matters too. Some are just more aggressive or harder to treat, and of course, how quickly treatment was started makes a difference.
So, delays can be problematic.
Definitely. And as we've stressed, older adults and people with significant underlying health conditions, particularly chronic lung or heart disease, are at higher risk of a poor outcome and complications.
Okay. Speaking of complications, what are the potential problems that can arise from bronchopneumonia?
We can think about short-term and longer-term issues. In the short term, the infection could potentially lead to a lung abscess forming.
A collection of pus.
Yes. Respiratory failure is a major concern, where the lungs just can't cope, potentially requiring support from a ventilator. Sepsis, that systemic infection response, is a life-threatening complication. You can also get a pleural effusion fluid building up in the space between the lung and the chest wall. And in really severe cases, it can progress to acute respiratory distress syndrome, or ARDS, which is widespread lung inflammation and fluid buildup.
ARDS sounds very serious.
It is. And then looking longer term, although less common, some people might develop some scarring in their lungs after a severe episode. And having had bronchopneumonia might make someone a bit more susceptible to getting recurrent respiratory infections down the line.
Okay, quite a range of potential issues there. So we've covered a lot of ground in this deep dive, haven't we?
We certainly have.
We've gone from defining bronchopneumonia, that patchy lower airway inflammation, through all the causes, the bacteria, viruses, fungi.
And aspiration.
And aspiration, yes. We looked at who's most at risk, how the disease actually develops in the lungs, what else it could be confused with.
The differentials, yeah.
How common it is, the typical signs and symptoms you'd see, and then the crucial investigations, the x-rays, CTs, lab tests.
Finding the bug.
Finding the bug. And finally, how we manage it with the right antimicrobials, good supportive care, and thinking about prevention too. Plus, keeping an eye on prognosis and potential complications.
Exactly. I think hitting those key areas, that what, why, who, how it presents, how we diagnose, and how we treat, really builds that solid framework you need for recall. Remembering those visuals like the patchy X-ray or the tree and bud CT can really help cement it.
Absolutely. And hopefully this discussion has made it all a bit clearer and more connected for you listening. Now, if you want to really test yourself and consolidate this knowledge further, definitely head over to passthemthesra.com.
Great resource.
And there's also excellent free content and questions available at freesra.com. Both are fantastic for reinforcing your learning.
Highly recommended.
So thanks for joining us on this deep dive into bronchopneumonia.
Yeah, I hope it was useful. Until next time.